see the slide? Okay, so we will be talking about parathyroid hormones. And when you talk about parathyroid hormones, that is actually pag-uusapan natin ay yung calcium and phosphate metabolism. Okay? Wait lang. Ba't ganito to? Sumaglit lamang. Okay, yan. So calcium and phosphate metabolism. So I always show this during the start of the lecture. This is an old commercial of Colgate. And what they're trying to show us in this commercial is that their toothpaste has a high calcium content. And on the commercial, upon brushing the eggshell with their toothpaste, what happened was it became strong. No? Tumigas yung or hard yung eggshell. And that is actually one of the effects of calcium in our body. To make not only our teeth harder and stronger, but also our bones. No, yan yung isang role ng calcium. That's why when you talk about the parathyroid glands and the hormone, we have to talk about the bone as well as its metabolism. Okay? We will also mention some other organs such as your liver, kidneys, and small intestine because yung calcium and phosphate metabolism somehow part ng metabolism itong organs na to. And then as we talk about parathyroid hormones, we have to talk, as we talk about calcium and phosphate metabolism, we also need to talk about another hormone, and that is your vitamin D. Okay? Yan. So let us first review the role of calcium. No, bakit ba importante yung calcium sa katawan natin? At dahil nakikita ko si Sir Hans, ito madalas ko rin itong ma-SGD si Sir Hans. Ano naalala mong role ng calcium, Sir Hans?
It supports the bone.
Okay. Ako sabi ko lang eh. Ang daya, di ba? Ito na lang, sige, magpas iba naman. Si Gail Ann. Oh. Si Gail Ann, parang hindi ko pa ito na SGD, no? Sa si Maria Clarissa. Ano, SGD na ba kita? Ano pang role, aside from sa bone ng calcium? Paano sa blood clotting? What do you mean blood clotting? Akala ko na-disconnect po ako, Doc. Ha? Oh, sige. Okay, sige. Isipin mo na, tama naman yan sa clotting, no? Ang isa pang nasa screen ko, si Maria Clarissa.
Sa ano po, Doc? Heart functioning. Regulating heart functioning.
So sa cardiac muscle contraction, parang ganyan, tama ba?
Opo.
Parang nag-isip pa talaga, di ba? Anyway, sige. So halos tama naman kayo, at least kahit pa paano may mga naalala kayo. Kulang lang yung naalala. Anyway, the role of calcium, yan nga sabi natin, for membrane excitation of nerve and muscles. So sa nerve, ibig sabihin, it will involve yung nerve conduction. So sa muscle, yun nga, muscle contraction, di ba? And then, and for that to happen, remember yung calcium should enter the tissues, di ba? And it can enter through specific channels by diffusion. Isa pang role ng calcium is that, it is important for the stabilization of the cell membranes. No? Later on, we will talk more about that, yung sa stabilization of cell membranes. Yan, nabanggit kanina, no? Yung importante for hemostasis. No, kung maalala ninyo, no, at least sometimes kahit pa paano naalala ninyo na for coagulation, di ba siya yung factor 4? Correct? Calcium is di ba yung factor 4? And then muscle contraction, not only skeletal but also sa cardiac. And then release of hormones and neurotransmitters. O yan, paano ba yung sa neurotransmitter, anong naaalala nyo? I-move ko, hindi ko ma-move eh. Sino pa ba? Ito, si Elvis. O, di ba? Pangalan pa lang, winner na. Elvis, anong sa tingin mo, paano nga sa neurotransmitter, ano yung role ng calcium? Sige, isipin mo muna Elvis. Tawagin ko muna si Seriza. Ito parang na SGD ko din madalas si Seriza eh. Mukhang kumakain pa si Sharice. Si Sharice Leyan, Legazpi.
Yes po, Doc.
Ito yung boto ko.
Yes,
Sharice
Yes po, Doc.
Leyan. Sharice ba yun?
Opo,
Anong
Doc.
paano yung role, paano ginagawa ng calcium for the release of neurotransmitters?
Sa ano po, Doc? Release, parang pang-trigger po nung sa synaptic vesicle. Parang,
Oh, okay. So kahit papaano no naalala ni Sharice yung sa yung yung vesicle sa presynaptic area. So somehow nando doon yon. Doon nangyayari para makatulong sa release ng neurotransmitter. Oh, kaya ako tinatanong, remember that during the finals, hindi lang ngayong SEM, no? Kasama yung last SEM. Kaya dapat naaalala ninyo yung first SEM. Okay? And then, calcium is also important, as you all know, for the production of milk. No? Kasi nga yung milk is high in calcium content. And then yan, I have mentioned for the formation of bone and teeth. So ano daw yung fate ng calcium sa ating katawan? If, for example, you will drink 1 liter of milk, pwede ka daw makakuha doon ng 1,000 milligrams ng calcium. So pagpasok nun sa stomach, towards the intestine, small amount lang ang ma-absorb from the intestine, only around 350 milligrams per day. And then, it will go to the ECF. And from the ECF, around 500 milligrams per day will be deposited sa buto. Okay? So 500 milligrams per day. At kung makikita mo nga dyan sa drawing, around 1 million milligrams per day or 1,000 grams of calcium are stored in the bones. Kaya nga sabi natin, sa calcium and phosphate metabolism, importanteng pag-usapan yung bones. Okay? And then, aside from deposition, an equal amount of 500 milligrams per day will also be absorbed or resorption naman, no? Coming from the bone, going back to the ECF. Kaya pag sinabi natin absorption or absorption, kaparehas yun ng resorption. Sa bone, pag deposition, yun yung deposited naman yung calcium. Okay? And you will notice that the deposition and resorption, it is equal, no? Parehas yan parate. And then from the ECF, around 9,980 will go to the urine, but only around 100 milligrams per day will be filtered out. Lahat yon mariri-absorb. And then again, 250 milligrams will be secreted back to the intestine, no? And then it will be excreted with the feces at around 900 milligrams per day. Okay? Yan. So, our calcium in the body is divided into the different compartments. Like, dun sa extracellular fluid, such as your plasma and interstitial fluid. 0.1% of the total body calcium are in the ECF. And then, sa intracellular, around 1% of the total body calcium. Nandun siya sa cells and organelles. Yan, sabi natin kanina pa, diba? Most of the calcium are in the bones. Ayan, around 99%. Kaya nga daw sa isang average size adult individual, around 1,000 grams of calcium ang nakadeposit sa buto. Okay? And then, if you will look at it, even phosphorus, around 80%, so majority din ng phosphorus, nakadeposit yun sa bones. Later on, you will see again why yung calcium and phosphate. No? Bakit laging kasama yung phosphate doon? Kaya halos parehas sila ng amount sa buto. So this is the normal values. Around 9 to 10 milligrams per deciliter ang normal calcium sa ECF. No? Around 9 to 10. Huwag na natin alamin masyado yung specific values kasi nga different books will tell us different values and actually even different laboratories. Pag tinignan niyo yung mga lab results, iba-iba. No? Pero at least alam natin that around 9 to 10 milligrams per deciliter ang normal. And take note that this is the extracellular calcium. Siyempre, yun yung nasa plasma, yun yung pwede nating what we can measure. But yung nasa loob ng cells and organelles, we cannot measure that. Okay? And then the calcium in the plasma, divided pa ito into somehow different types. Okay? Some of the calcium, around 41%, are combined or attached with a plasma protein. Okay? And knowing that protein is a big molecule or large molecule, and then aside from that, it is negatively charged. Calcium that are combined with protein cannot diffuse through capillary membranes. Hindi sila makakapass through kasi negatively charged yung capillary membrane, di ba? So marerepel, tapos malalaki yung protein, hindi siya makakapass through capillary membrane. So what's the significance of knowing that? Ibig sabihin, itong mga calcium, when they are attached to a protein, the cells or the tissues cannot utilize that because the calcium cannot go to the tissues. Okay? Another type in the plasma are those calcium that are combined with anionic substances such as citrate and phosphate. O makikita natin uli mamaya yung calcium, no? Kasama niya yung phosphate doon sa buto natin. Okay? So kapag ka ganun, other cells can no longer utilize that. Same thing with citrate. No? Because these are anionic substances or negatively charged. So it cannot pass through the membrane. Diba? For medtech, saan nyo madalas nakikita yung citrate? Anybody? Sino bang mga medtech dito? Laging nauubusan tayo ng medtech, no? O anyone, saan nyo ba nakikita yung citrate? O clue na yon, medtech ang sinabi ko.
Sa vacutainer.
Yun, ang galing na nasa vacutainer or yun sa yung diba yung tube, no? So tama yun kasi may mga citrated tubes tayo, 'di ba? Citrated tubes. Yung vacutainer kasi is branded, 'di ba? Anyway, so yung mga citrated tubes, so anong nangyayari if the calcium, yung pag nilagay mo yung blood doon, the calcium in the blood now will be attached with the citrate in the test tube. So what will happen now? Yung calcium, somehow, the blood cells can no longer utilize that. So hindi magka-clot yung blood. Same thing with, or magko-coagulate. Ganun din yung mga transfer bags. Yung mga bags na pinaglalagay ng blood kapag magta-transfuse, yung transfer bag na yun also contains citrate. Okay? That's why the most important form of calcium in the plasma are the ionized one or yung free calcium. And around 50% of the calcium in the plasma are ionized. Kasi nga, sila yung can be utilized makakapass through sa membranes and it can be utilized by the different cells and tissues of the body. Okay? And then we mentioned already that most of the calcium are in the bones. And we have two types, yung tinatawag na cortical and trabecular bones. 99% of the total body calcium are in the cortical bones. That's why it is considered as the larger calcium pools or large calcium pool. And then less than 1% are in the trabecular bones. If you will compare cortical bones and trabecular bones, cortical bones are somewhat harder because sila yung merong bone salt deposition, more bone salt deposition. Yung trabecular bones, somehow they are softer compared to cortical bones. That's why yung trabecular bones, this is our immediate source for sudden decrease in calcium levels. Okay? This is just to show us that the calcium in the plasma, ayan ulit, 50% are in the ionized form. Okay? As I have mentioned, kung nasan yung calcium, nandun din halos yung phosphate. No? Around 80 to 85% are in the bones. Ang kaibahan lang nila dito, mas madami sa cells talaga. 14 to 15% ng phosphate ay nasa cells and around less than 1% ang nasa extracellular fluid. Okay? Yan. Ito halos parehas din sa Bernoulli level lang ito. Yan. Yung inorganic phosphate in the extracellular fluid, meron pa yung dalawang uri. yung hydrogen phosphate and dihydrogen phosphate. If if the phosphate is increasing in the plasma, most likely daw both types are increasing. However, if there are changes in the pH, like for example, nagde-decrease yung pH natin, most likely the one that will increase is your dihydrogen phosphate. And your hydrogen phosphate will decrease. And kung alkalotic, yung kabaliktaran naman yung mangyayari. The problem with this phosphate is it is very difficult to measure. Ang pwede daw nating i-measure are yung inorganic phosphorus, yung milligrams of phosphorus per deciliter, and the average is around 4. Okay? 4 milligrams per deciliter. Okay? So ano naman yung role ng phosphate? Okay? So isang alam natin, no? Yung phosphate, this is a key intracellular component. That's the reason also why kung nakita nyo kanina, taas, no, around 15% nandun siya sa intracellular, hindi sa ECF. And alam natin that phosphate is a component ng energy that is produced by the different anong tawag dito, processes in the body. Yung tinatawag nating ATP. Correct? That's why yung phosphate important for phosphorylation and dephosphorylation of proteins, lipids. Second, it also acts as second messengers and cofactors. It is also part of the backbone of the nucleic acids. Ito yung isang important role ng phosphate aside from being part of the important bone salt. No? Okay? Yan. So let us continue unless you have questions. Okay, so in calcium and phosphate metabolism, as I have mentioned in the start, we have to talk about 2 hormones, and that is your parathyroid hormone and vitamin D. And these 2 hormones are known to be calciotrophic. So let's start with parathyroid hormones. Parathyroid hormones controls the amount of the extracellular calcium and phosphate by regulating intestinal reabsorption, renal excretion, and exchange between ECF and bones. No? So it regulates not only to make it high also, but to make it normal. Okay? So if you have excessive parathyroid hormones, what will happen? You will have hypercalcemia. Kasi nga calciotrophic siya, di ba? Kung decrease yung parathyroid hormone mo, hypocalcemia naman. Okay? So bakit daw parathyroid? It is parathyroid kasi alam natin, di ba, pag para, it is near or beside. No, kaya siya parathyroid. The parathyroid glands are near, no, or beside the thyroid glands. And we actually have 4 lobes. 4 lobes. So what's the significance of knowing that it is beside the thyroid gland? Let us say, for example, you have a problem in your thyroid gland. Sabihin na lang natin, cancer of the thyroid. And then your thyroid has to be surgically removed. Okay? If you will undergo surgery or if the patient will undergo surgery, there's a high chance that the parathyroid gland will also be removed. So pakakasama siya, matatanggal din, no? So if for example, 2 lobes of the parathyroid will be removed, there's no problem because you still have 2 other lobes that can produce enough parathyroid hormones. What if 3 parathyroid gland lobes will be removed? So this time, only 1 lobe will remain. Initially, you will become hypoparathyroid. Hypoparathyroid. Kasi from 4, naging 1. So medyo mababawasan yung supply mo ng parathyroid hormone. However, this remaining lobe of parathyroid gland can hypertrophy. Pwede siyang lumaki. So kapag lumaki na siya, it can now produce enough parathyroid hormones for you to use. Maliwanag? So initially, kung 3 lobe, magiging hypoparathyroid ka. Pero pwedeng mag-hypertrophy yung remaining lobe, and then later on, magiging normal yung parathyroid hormones mo. Siyempre, kung 4 yung matatanggal, definitely, hypoparathyroid ka na. Okay? Yan. So, sabi natin kanina, it controls yung amount ng extracellular calcium. No, it controls. And your calcium as well controls the release of your parathyroid hormones. Okay? So kung may parathyroid hormone ka, kokontrol niya yung calcium mo. No? Ngayon, kung yung calcium mo din, halimbawa, mababa yung calcium mo, it also controls yung release ng iyong parathyroid hormone. Okay? Bakit daw ganon? If you will look at this one, at this drawing, tingnan natin yung calcium. No? Kasi meron tayong mga tinatawag na calcium sensing receptors. Okay? Kung normal daw yung calcium mo, that will be sensed by your calcium sensing receptor. Kung normal or mataas. So what will happen now is that the calcium sensing receptor will inhibit yung parathyroid hormone gene. Yung parathyroid hormone gene kasi, siya yung responsible for the expression of your parathyroid hormones. Okay? So kung halimbawa naman, mababa yung calcium mo or below normal. Okay, what will happen now? Your calcium sensing receptor will detect that, and then instead of inhibition, it will cause stimulation ng parathyroid hormone gene to express your parathyroid hormones. Para kung may parathyroid hormone ka na, it can now serve its function. No? Kasi nga sabi natin, calciotrophic yung parathyroid hormone. Okay? So yun yung ginagawa ni calcium sensing receptor gene. Okay? Ni calcium sensing receptor, I'm sorry. Si vitamin D naman daw, if you will look at your vitamin D, in the presence of your vitamin D, it also stimulates, it inhibits your parathyroid hormone gene. And then it can promote yung expression ng calcium sensing receptor gene. Okay? So ngayon, si vitamin D, pwede niya palang inhibit, in the presence of vitamin D alone, pwede pala niyang inhibit yung parathyroid hormone gene. Okay? So but, ang sabi doon, kapag daw mababa yung calcium mo, nanenegate niya yung effect ni vitamin D. Okay? So sa halip na inhibit niya, nagiging stimulatory din siya. Okay? So yun yung effect ng parathyroid hormone ni calcium sa release ng parathyroid hormones. Okay? Yan. So si parathyroid hormone, it increases calcium concentration by increasing calcium and phosphate absorption from the bone. And then it decreases excretion of calcium in the kidney. Or sa madalit sabi, it increases reabsorption of calcium in the kidney. Okay? The reason for that is because yun daw receptors for calcium, the receptors for the parathyroid hormones are present in the bones as well as in the kidneys. Kaya sila yung effect ng parathyroid hormone, it directly affects the bones and the kidneys. How about for phosphate? So for phosphate, it increases renal excretion. So kabaligtaran, sa kidneys, increase ang renal excretion ng phosphate. Okay, so this is a parang summary of what happens when you have decreased calcium. So if you have decreased calcium, that will be detected by your calcium sensing receptor. So it will promote yung expression or release of your parathyroid hormones. If you have parathyroid hormones, this will promote bone resorption. No? So magkakaroon ka ng calcium efflux. It will now increase your calcium in the plasma. How about for the kidneys? So for the kidneys, ang effect ni parathyroid hormone is one, increases calcium reabsorption and then decreases phosphate reabsorption. Ang isa pang effect niya sa kidneys is that it will activate your vitamin D. And once you have active vitamin D, that vitamin D now will increase the absorption of both calcium and phosphate in the intestine. Kaya kung titingnan ninyo, si parathyroid hormone pala, wala siyang direct effect sa intestine. Ang merong direct effect sa intestine ay yung vitamin D. Okay? So indirectly, affected niya lang yung absorption sa intestine by activating your vitamin D. Okay? Yan. So sabi natin, ano yun? Yan, yung Yung bones are the storage or yung storage ng ating calcium. So our body will get calcium from the bones. No? If for example, mababa yung calcium natin. Okay? So yung metabolism ng bone to get calcium, meron yung rapid and slow phase. Yung sa rapid phase, this occur in minutes to several hours. And this occurs in the trabecular bones. And the process responsible for it is yung tinatawag nating osteocytic osteolysis. And that is controlled by your osteocytes with the stimulation of your parathyroid hormones. Okay? So sa trabecular bone yan. Yung slow phase naman, this occurs in the cortical bone or yung tinatawag nating larger calcium pool. And this time, this is the cells responsible for this will be yung osteoclast. And syempre yung osteoblast din. No? Again, later on, we will go back to this slow phase na tinatawag. Okay? So again, for the excretion and reabsorption of calcium, it occurs in the proximal tubules, loop of Henle, and early distal tubules, and 10% on the late distal tubules and early collecting ducts. Okay, for phosphate, it diminishes yung effect ng parathyroid hormone. It diminishes yung reabsorption ng phosphate in the proximal tubules. Okay, for renal phosphate overflow mechanism, for renal phosphate absorption, we should also know this tinatawag na renal phosphate overflow mechanism. Kasi si phosphate daw, meron siyang critical value of around 1 millimole per liter. So yung amount niya in the glomerular filtrate should be 1 millimole per liter. Kaya kung halimbawa, yun daw phosphate mo is below 1 millimole per liter in the filtrate, all the phosphate now will be reabsorbed. But if the phosphate is more than 1 millimole per liter, excretion is directly proportional to the additional phosphate. So ano ibig sabihin noon? Kung halimbawa 3 millimole per liter yung phosphate mo sa filtrate, yung 2 millimole per liter doon will be excreted. So dapat nandun lang siya sa 1 millimole per liter. Okay? Yeah, so that's for parathyroid hormones. Let us now go to vitamin D, yung isa pang hormone na importante sabi natin. So vitamin D, it increases calcium absorption, as you have seen, no, by increasing yung absorption ng calcium sa intestines. But it is also important in bone deposition and absorption. Kaya makikita natin, mamaya explain natin ulit yan. So the most active form of your vitamin D is your 125 dihydroxycholecalciferol or dihydrovitamin D. Okay? Yan. So, saan ba nakukuha yung vitamin D daw? Tignan natin. So, in our skin, we have sterol compounds. Okay? We have sterol compounds. Yan, no, yung 7-dehydrocholesterol. If this cholesterol, no, itong sterol compound na to, is exposed to ultraviolet B rays, no, or na-expose ka sa sunlight, it will be converted into vitamin D3 or yung tinatawag nating cholecalciferol. Okay? Kaya maganda daw yung nabibilad ko sa araw. Ano pa bang pwedeng source natin ng vitamin D? Pwede rin vitamin D2. Vitamin D2, we can get that from plants. No? So vegetables. So if you are fond of eating vegetables, pwede ka makakuha ng vitamin D2. Okay? So anyway, this vitamin D3 and vitamin D2, they are both inactive. So it has to be activated. So they have to be brought to the liver. No? It can be brought to the liver through the blood or through the lymphatics. Ay makikita nyo, vitamin D chylomicron or sa portal blood kung galing sa enterocytes such as your vitamin D2 or kung D3 yan sa cabal blood or pwede rin sa lymphatics. Okay? So from there, mapupunta siya sa liver. Once in the liver, and once it is acted upon by 25-hydroxylase, it will become 25-hydroxyvitamin D. Okay? But still, your 25-hydroxyvitamin D, hindi pa siya active. It has to undergo further activation sa kidneys. Okay? Once in the kidneys, and once it is acted upon by 1-alpha hydroxylase, your 25-hydroxyvitamin D will now become 125-dihydroxyvitamin D or 125-dihydroxycholecalciferol, or yung iba pang terms dyan, calcitriol, no? Calcitriol. So kapag 125-dihydroxyvitamin D, active na siya kasi siya yung merong biological effects sa intestine, bone, and kidneys. Kapag daw yung 25-hydroxyvitamin D mo is acted upon by 24-hydroxylase, magiging 24-25-dihydroxyvitamin D siya. Or kung minsan, yung active vitamin D mo, ma-acted upon ba siya pa ng 24-hydroxylase, magiging 12425 siya. Okay, kapag kaganon, itong forms ng vitamin D na yan, yung 2425 and 12425, wala silang biological effects. Kaya ang pinaka-active natin is your 125-dihydroxyvitamin D. Okay? Bakit naman daw sa kidney yung final activation? Kaya sa kidneys yung final activation kasi yung gene expressing 1-alpha hydroxylase are found in the kidneys. Okay, yan, yung CYP27B1. And the expression of that gene is actually controlled also by your parathyroid hormone. Okay, kaya makikita natin yung final activation of your vitamin D occurs in the kidneys and also needs parathyroid hormone. Kasi nga, ayan, siya yung nag-stimulate sa expression ng gene that will, anong tawag dito? Simulate yung release ng 1-alpha hydroxylase. Okay? Okay. So again, this one is in your guide, Ton. No? If you have your vitamin D3 in the skin, your cholecalciferol, it should be first activated in the liver to become your 25-hydroxycholecalciferol. If you need your vitamin D, further activation with the control of your parathyroid hormones will occur in the kidneys for it to become 125-dihydroxycholecalciferol. Okay? So once you have that active vitamin D, it can now increase yung intestinal absorption of calcium through the action of your calcium-binding protein or calbindin, calcium-stimulated ATPases, and alkaline phosphatases. All of these will increase yung absorption of calcium in the intestine. Okay? If, for example, and then, so once na mataas na yung calcium mo sa plasma, it will now inhibit your parathyroid hormone, so mai-inhibit yung final activation ng 25-hydroxycholecalciferol. Okay? So kapag hindi mo kailangan yung 25-hydroxycholecalciferol mo, si 25-hydroxyvitamin D or 25-hydroxycholecalciferol also has the capability of inhibiting yung conversion ng cholecalciferol to 25-hydroxyvitamin D. Bakit? No? Mas maganda daw kasi yung vitamin D mo stored as cholecalciferol or vitamin D3. Kasi kapag 25-hydroxycholecalciferol siya, unstable. So madali siyang masira. Okay? Kaya nga halimbawa, yung vitamin D3 mo sa skin, laging nako-convert sa liver, hindi mo naman kailangan. Pwedeng maubusan ka ng supply. Unlike kapag nasa skin siya, mas stable siya, so it can be stored in the skin. Okay? So that's how vitamin D increases yung absorption ng calcium in the intestine. Okay? So, paano ba nangyayari daw dun sa calbindin, no? Sa calbindin, yung how does it help to increase yung absorption ng calcium? So tingnan natin uli ito. So sabi natin kanina, this is your enterocyte, no? Enterocyte to, or yung cells sa intestine. So this is the luminal side, this is the serosal side. So paano ang nangyayari? So remember your calcium, no? Halimbawa, kumain ka na, nasa luminal side na. Your calcium can go inside the enterocytes by diffusion through channels. Okay, through channels. So yung channel niya, ayan, TRV5 or TRV6. Okay? So sabi natin, by diffusion, diba, it's the movement from a high concentration to low concentration. So papasok na yung calcium mo dito. Papasok siya. Diba? Pagpasok niya dito, tataas na yung calcium sa taas. So kapag mataas yung calcium sa loob ng cell or sa loob ng cell, what will happen? So mawawala ng gradient. So mag-slow down yung pag-move ng calcium towards the enterocytes. So isang role ng cal binding is that your calcium now, kapag nasa loob na ng cell, it will bind with your cal binding. So kapag nakabind na siya doon, hindi na yon free calcium. Kumbaga hindi na siya somehow considered as free calcium inside the intestine and inside the enterocytes. So magkakaroon uli ng gradient. So patuloy uling papasok yung calcium natin doon sa intestine. Sa enterocytes, doon sa intestinal cell. Okay? So yun yung role ni cal binding. So somehow parang nadidecrease niya yung concentration ng free calcium in the enterocyte. So nagkakaroon ng gradient. So diffusion will continue. And then once attached to your cal binding will shuttle, para din siyang parang ita-transport niya towards the serosal side. And through the plasma membrane calcium receptors, it can now be secreted towards the serosal side. Okay, so yun yung role ni cal binding. That's why in the presence of your cal binding, tumataas yung absorption ng calcium in the intestine. Okay? Yan. So, kung makikita natin, kung kanina si parathyroid hormone, it controls yung release. So parathyroid hormone na nagko-control ng release, yung calcium. Ganon din kay vitamin D. No? Kung halimbawa, mataas yung calcium mo, more than 9 to 10. So, hindi mo kailangan ng vitamin D. So, it will suppress your parathyroid hormones. Kung walang parathyroid hormone, walang final activation ng vitamin D. Okay? Kung mababa naman yung calcium mo, it will stimulate the release of your parathyroid hormones so that your parathyroid hormone can activate your vitamin D. Okay? Can activate your vitamin D. So again, this will increase absorption of calcium and phosphate in the gut, bones, and in kidneys. No? So kailangan din siya talaga sa absorption, sa kidneys as well as sa bones. Okay? Since we're talking about calcium and phosphate metabolism, we also have to talk about, worth mentioning yung calcitonin. Calcitonin is a peptide hormone produced by your thyroid gland. It has the opposite effects of your parathyroid hormone. So lahat ng binanggit natin kanina, kabaliktaran niya. Okay? But in terms of calcium and phosphate metabolism, the effect of your calcitonin is weak in humans. Now, for calcium and phosphate metabolism daw, ang pinaka-importante ay si parathyroid hormone. Kasama na rin si vitamin D. Okay? Yan. You have any question at this point in time?
Wala po.
Okay, very good. Yan. Yung gusto ko sa inyo, laging walang question, no? Sige, ako na lang mag-question mamaya. Okay, so let us review yung cellular aspect naman ng bone metabolism. So makikita natin dito kung paano yung bone resorption and bone deposition. Okay? So let us first review yung different cells ng bones. Although I know that napag-aralan ito in detail in your histology. So banggitin lang natin yung importance nitong mga different cells na to. So your osteoblasts, alam natin that these are highly differentiated cells. They are bone-forming cells and they're the ones secreting and synthesizing collagen. Collagen kasi yan yung majority or major component ng bone matrix. Okay? It has abundant alkaline phosphatase activity and it is derived from bone marrow mesenchyme. For osteocytes, these are osteoblasts that are buried in the matrix. Okay, ano ibig sabihin nun? Kasi di ba si osteoblast, sabi natin kanina, magsisecrete siya ng collagen. Kapag yung collagen na yon nag-polymerize or nagdikit-dikit na, it will cover some of the osteoblasts. And once that happens, that osteoblast now na na-cover nung collagen will become osteocytes. So this osteocytes, they are not capable of producing collagen. But as I have mentioned earlier, They are the one responsible for the osteolytic osteolysis no, ng trabecular bones. And again, this is through the action of your parathyroid hormone. Diba? Kaya yung rapid movement of calcium from the trabecular bones to the ECF, that is through the action of your osteocytes, to the process of osteocytic osteolysis. Yung osteoclasts naman, these are large multinucleated cells with lysosomes. And you know that lysosomes, they contain enzymes, no? Such as acid phosphatases. It can also secrete lactic acid and hyaluronic acid. And these enzymes and acids can be used to digest yung bone salts. And the release of that acid is actually secreted by your parathyroid hormone. And actually, hindi lang yun. Yung mismong pag-mature ng osteoclast is controlled by your parathyroid hormones. Okay, this is a simple illustration ng bone cells. Mapapansin nyo yung osteoblast, magkakatabi sila at parati silang may katabing osteoclasts. And yung blue material, yung osteoid, yan yung collagen na nag-polymerize. Once na makover niya yung ibang osteoblast, it will now become osteocytes. Ito pa ang another illustration. Makita nyo yung osteoblast, tabi, tapos biglang may osteoclast, no? Okay? Yan. So, si osteoblast daw will secrete collagen monomers as well as ground substances. And once this collagen monomer polymerizes, it will become your osteoid. Osteoid is soft, no? Para siyang cartilage. Kaya siya tinawag na cartilage-like material. But it is not the same as your cartilage because it has one property that makes it different from a cartilage. Okay? This osteoid, pwede siyang magkaroon ng calcium salt deposition. No? Or calcium salts can precipitate dun sa osteoid na yon. At yung mga calcium salt na ito, yung tinatawag nating calcium salt or bone salts, ito yung tinatawag nating hydroxyapatite. Okay? Pag nag-precipitate ng calcium salt together with your phosphate, it will become your hydroxyapatite. And some of the bones will still remain amorphous. Yan yung nagiging trabecular bones. Okay? Yan. So sabi ko kanina, the major component of the organic matrix are your collagen fibers. No? Around 90 to 95%. And again, this is secreted by your osteoblast. Same thing with your ground substance. Yung collagen fibers, siya daw yung responsible for tensile strength ng buto. Kaya yung buto, pag daw hinila mong ganyan, hindi mo siya basta-basta mapipigtas. Okay? Hindi siya basta-basta mapipigtas. And then yung ground substances are chondroitin sulfate and hyaluronic acid. Yung tinatawag nating bone salts, no? This time it gives compressional strength to the bone. No? Kung kanina, tensile strength. Ngayon, yung compressional strength naman, kapag daw yung buto natin, pinukpok mong ganyan, hindi siya basta-basta mababasag. And the one responsible for that are the bone salts. No? And yung bone salts natin are actually made up of calcium and phosphate together with a hydroxide. Yan yung tinatawag nating hydroxyapatite. Siya yung bone salt na nagpapatigas dun sa buto. Ito yung reason din why, sabi natin kanina, 90% of the calcium are in the bones and 80% of your phosphate are in the bones. Kasi nga, sila yung dalawang magkasama para maggawa yung hydroxyapatite. Okay? Other salts such as your magnesium, sodium, and potassium and carbonate can act as bone salt. However, kapag sila hindi kasing tigas ng calcium and phosphate. Other elements such as strontium, uranium, plutonium, lead, and gold can also be deposited and act as bone salts sa buto. However, if that will happen, it can lead or it may lead to the development of osteogenic sarcoma. Ano ba yung osteogenic sarcoma? This is the cancer of the bones. No? Na pag-aralan nila to, they learned about this, no? Yung especially after the Hiroshima bombing. Naalala niyo ba from your history when the Americans bombed yung Japan, di ba? They used an atomic bomb. Kasi before yung atomic, ngayon nuclear bomb ang tawag eh. Pero yung atomic bomb, nuclear bomb din nun. Actually, nuclear bomb din yun. So, di ba, yung mga strontium, uranium, plutonium, yan yung mga ginagamit sa mga nuclear reactor, nuclear bomb. Okay? Yung mga napag-aralan nila after the Hiroshima bombing, maraming nagkaroon ng cancer ng buto. And then we'll try to look at the bones, napansin nila, meron deposition ng strontium, uranium, or even plutonium. So kaya yan, pwede siyang mag-cause ng cancer. Okay? From the start of the lecture, I have mentioning that yung calcium and phosphate, nakikita siya not only in the bones, meron sa plasma, meron sa cells. How come in the other parts of the body, it does not precipitate and become hard? No? Kasi nga daw, dun sa other tissues of the body, meron tayong tinatawag na pyrophosphate, which inhibits the precipitation of calcium and phosphate. And this is found in all tissues. No, sa lahat ng tissues ng katawan. Okay? How about yung tissue non-specific alkaline phosphatase or yung tinatawag nating TNAP. No? Again, this is secreted by your osteoblasts. This time, it neutralizes your pyrophosphate. No? Kanina, nabanggit natin, no? Sabi natin, pyrophosphate inhibits precipitation. It is found in all tissues. Dito, nabanggit natin that your osteoid, meron siyang capability to have precipitation or deposition of bone salts. Bakit ganon? Si osteoid kasi, meron siyang TNAP, no? Which inhibits your pyrophosphate. Kaya siya, sabi ko kanina, cartilage-like material lang siya. Yung cartilage, wala siyang TNAP. No? Kaya yung may pyrophosphate yung cartilage, kaya siya, it remains soft, no? Walang bone deposition. Walang bone salt deposition. Pero si osteoid, in the presence of your TNAP, which neutralizes your pyrophosphate, pwede siyang magkaroon ng bone salt deposition. That's why yung osteoid, it can become hard. Okay? Another thing that you should remember in terms of ng pyrophosphate is your NPP1, yung nucleotide pyrophosphatase phosphodiesterase 1. This is also produced by your osteoblast. No? Kaya makikita niyo si osteoblast, napaka-busy. No? Napaka-busy niya. Siya yung nagpo-produce ng pyrophosphate or one of the components that is used for the production of pyrophosphate. Si ankylosing protein naman, it transports your pyrophosphate. No? So after production, it is used to transport pyrophosphate to the different tissues. Kaya yung pagka nagkaroon ka daw ng deficiency ng A and K, it can lead to the development of ankylosing spondylitis. Ano ba itong ankylosing spondylitis? Ang isang manifestation niyan, nitong mga patients with ankylosing spondylitis, they have stiff and painful joints. No? Bakit ganon? Kasi remember, in between the joints, meron yung cartilage. So kung walang pyrophosphate, what will happen now to the cartilage? Pwedeng magkaroon ng deposition ng bone salts. Okay? So titigas yung cartilage doon. So kapag nangyari yon, kapag ginalaw mo yung joints mo, masakit. Saka stiff. Ganun din yung spine niya. Spine nila. Kasi nga di ba yung spine may cartilage in between yan. So kapag yun ay tumigas, what will happen now? No? Painful yung movement. Kaya meron silang back pain, especially in the lumbar area. Okay? So yan yung ankylosing spondylitis. Okay. So let us now look at this absorption of your cortical bones. So sabi ko kanina sa inyo, we will go back and talk more about it. No? So kung si osteocytes responsible for osteocytic osteolysis, si osteoclast naman ang responsible for the slow phase occurring in the cortical bones. Okay? So, anong nangyayari? So your parathyroid hormone as well as your vitamin D will stimulate your osteoblast. No? Si osteoblast na naman. So busy-busy siya. So once that happens, halimbawa mababa yung calcium mo, no? Your osteoblast now will stimulate the release of your RANKL. No, yung receptor activator nuclear K ligand. Okay, this RANKL will stimulate, no, yung or will bind to the receptor, yung RANK, found in your immature osteoclast or pre-osteoclasts. Okay? Same thing with your monocyte colony stimulating factor. Once na nag-bind na yan sa mga immature osteoclast. It will promote its maturation. So magiging mature osteoclast na siya. Kapag mature na yung osteoclast, sabi natin meron siyang lysosome, no? Meron din siyang mga acid. So these acids now will be released. So it will be used for the digestion ng bone salts found in the cortical bones. Okay, so kapag ka na-digest na yon, ano ba yung bone salt? Hydroxyapatite made up of hydroxide, calcium, and phosphate. So calcium will be released to the plasma as well as phosphate. Okay? So ganon. So halimbawa, ano mangyayari kung nag-normalize yung calcium na? Or, di ba sabi natin, continuous yung bone resorption and bone deposition. No? After kasi a few days or weeks, madedetect na yun ni osteoblasts. No? Madedetect na ni osteoblasts. So si osteoblast din ang mag-i-inhibit ng maturation ng pre-osteoclast. No? So kaya busy si osteoblast. No? So pag na-detect niya, normal na yung calcium. Okay? Si osteoblast will promote the release of your osteoprotegerine. Okay? It will promote the release of your osteoprotegerine. So once na-promote niya yung release ng osteoprotegerine, this will bind with the receptor of your RANKL. So once nakabind na siya dun sa receptor ng RANKL, yung mga RANKL can no longer bind to the receptor, may inhibit yung maturation ng pre-osteoclasts. Maliwanag? Kaya nga sabi natin, busy si osteoblast. And if you will notice, dito sa slow phase and dito sa bone resorption, o kanina sa bone deposition, importante si parathyroid hormone, di ba? Dito, importante pa rin si parathyroid hormone at vitamin D sa bone resorption. Okay? Okay. Yan. So tingnan lang natin kung halimbawa may mga ano yung effect ng ibang hormones and substances dito sa pinag-usapan nating slow phase na yon. Kagaya ng glucocorticoids. No? If for example, you have a patient in prolonged glucocorticoid therapy, no? Siguro yung mga months, ganyan, no? 1 month, 2 months, what will happen now? Yung glucocorticoids, it will promote osteoclast activity by increasing RANKL and decreasing OPG. So anong ibig sabihin nun? Mapopromote niya yung maturation ng osteoclast. So kung maraming mature osteoclast, what will happen? Maraming bone resorption. So kung maraming bone resorption, what will happen to your bones? Your bones now will become thinner or weaker. Kasi di ba continuously natatanggal yung bone salt. Di ba? Kaya yung mga patients in prolonged glucocorticoid therapy, what happens now is their bones will become thin and brittle. That's why, or weak. Sabihin na lang natin, weak na kasi nga manipis na siya. It will now become brittle, so they are prone to fracture. No, they are prone to fracture. No, kung nagbasa kayo ng renal before, nag-research kayo, siguro na-encounter niyo yung nephrotic syndrome, di ba? Aside from nephritic, merong nephrotic. Yung mga nephrotic syndrome, ang isang treatment dyan is prolonged corticosteroid treatment. Kaya itong mga pasyente na to, no, they are somehow they have weak bones and they are prone to fracture. Okay? Pero hindi naman lahat. Pero may chance na magkaroon na mangyari yun. How about estrogen? Si estrogen naman, it stimulates OPG production. Di ba kanina nakita nyo si OPG, siya yung responsible for the inhibition ng binding ng RANKL. No? Parang competitive inhibitor siya dun sa RANKL receptor. So in the presence of OPG, walang maturation ng osteoclasts. Diba? Kaya nga yung mga women, pre-menopausal age, they are somewhat protected from osteoporosis. So low yung risk ng osteoporosis pre-menopausal. Pero pag post-menopausal age na sila, tumataas na yung risk for osteoporosis kasi nawawala na yung effect ng estrogen na yan. Okay? Okay, so we mentioned also that deposition and absorption or resorption of bone is in equilibrium. No? Parang same amount. Pag may na-deposit na ganito, meron ding matatanggal na ganito. And ano yung importansya nung bakit gano'n na may deposition and absorption? Kasi nga daw, yung mga buto natin, yan yung bones natin since we are still a fetus. No? Lumaki lang ng lumaki, lumaki ng lumaki. So with the continuous deposition and absorption, somehow, there's renewal of the old degenerated organic matrix. Okay? Another thing that you should take note of is that yung bone deposition, this is actually affected by bone stress. Okay? Affected by bone stress. Ano ba yung bone stress? Like for example, kung mahilig ka mag-jogging or mag-run, yung pagtakbo mo, yung constant pounding ng feet mo sa ground, that is equivalent to stress. No? So yung stress na yon will be applied to the feet, not only to the feet, but also the bones of the lower extremities and even your spine and your pelvis as well. Kasi connected yun, di ba? So habang tumatakbo ka, di ba? Nagkakaroon ng stress doon sa buto mo. And that will promote bone deposition. No? And take note that pag mas marami kang bone deposition, mas marami kang calcium salts, hydroxyapatite, nagiging denser, no? Denser yung buto mo, mas tumitibay siya. That's why nakita dyan, bone strength is proportional to bone stress. Kaya yung mga athletes, they have a higher bone density compared to individuals who are sedentary. Okay? Or even yung may mga active na trabaho, basta compared to sedentary, mas mataas or heavier yung bone density nila. And that is because yung bone stress equating to bone deposition. Okay? And then yung bone deposition and absorption, this will actually also affect rearrangement of the shape of the bone. Okay? And isang effect din yan ng bone deposition, di ba mapapansin niyo, it also affects yung paghaba ng buto natin. Kasi nga, pag continuously may bone deposition, humahaba din yan. Tapos lumalaki din yung mga extremities nyo. Ganun din yung mukha natin. If you remember, when we were still a baby, bilog na bilog yung mukha natin. No? So aside from baby fats, kasi nga yung bone mo, wala pa masyadong bone deposition. But as we grow older, nagkakaroon ng bone deposition, di ba, nagkakaroon ka ng high cheekbone, yung jawline mo affected din. Although may effect, alam natin may effect din yung growth hormone doon. Pero may effect din doon yung bone deposition. Okay? So yun. Ang isa pang effect daw niyan sa rearrangement of the shape of the bone, kung halimbawa, na-fracture ka, okay, nabalian ka. Remember that yung buto natin, ano ba yung buto natin? Straight yung buto natin, di ba? Ganyan. Kung nagkaroon ka ng fracture, kung minsan ganyan lang, crack lang, okay lang yan. Madaling gamutin. Pero sometimes, pag na-fracture ka, no, nawawala siya sa pagiging straight. Ganyan, no? Displaced, no? Displaced siya. So kapag ganyan, tas nagiging tabingi pa ng konti, anong gagawin? Dadaling ka sa ortho. Especially before, ang ginagawa lang kung hindi naman ganong sirang-sira yung buto mo, is external reduction. Anong ibig sabihin ng external reduction? Kung nung nag-crack yung buto mo, ganyan, tapos wala ka namang injury sa skin, no? Hindi mo makita mo lang through x-ray, nakaganyan siya yung buto mo. Unti-unti yung itutuwid by manipulating your extremity, tutuwid ng ortho. Until such time na tuwid na siya. Diba yan yung tinatawag na external reduction. After that, lalagyan ka ng external fixator. No, para wag gumagalaw yung affected limb. And that is through yung application ng plaster of Paris. Kita niyo yun, di ba kung pag may pilay, yung may maputing ganyan? Plaster of Paris, or in layman's term, kung tawagin natin before, semento. No, sinesemento. Kapag gano'n, ang isang pwedeng mangyari ay sometimes pag nag-heal yung buto natin, no, hindi na siya ganun ka-straight. No, may konting angulation. Kasi maari nung nag-external reduction, hindi masyadong naituwid, or nung naka-external fixator ka na, nagagalaw mo siya, pwedeng maging ganito. Hindi siya mag-heal straight. So ano yung role ng rearrangement of the shape of the bone dyan? Kapag ganito daw, yung bone deposition will favor the inner angle. So dito siya magde-deposit ng magde-deposit. Okay? And then bone resorption will favor the outer angle. So dito naman, bone resorption. So later on, pag nagpatuloy yung continuous deposition and resorption, di ba? Tingnan mo yung angle, magiging straight siya uli. Okay? Magiging straight uli yung bone mo. And once that happens, there will be proper distribution of support of mechanical forces again. Kasi nga, pag tabi yung buto mo, mahirap din, hindi rin tama yung pagkilos ng buto mo. Pero pag na-straighten up uli yun, tama na uli yung distribution ng mechanical forces. Okay? But this straightening, hindi yan agad-agad. No? It will take some time. Okay? Is that clear? So yan yung isang, yan yung mga importansya ng deposition, continuous deposition and absorption of the bone. Okay? Yan. Let us now go to some effects, no? If yung calcium levels natin as well as phosphate will be altered. Yan. Kapag daw decrease yung calcium natin, it will increase yung secretion ng parathyroid hormones. Okay? So kung parating ganun, mababa yung calcium mo, laging na-stimulate yung release ng parathyroid hormones, yung parathyroid gland will hypertrophy. Okay? Such as in cases of rickets and pregnancy. Kasi nga sabi ko sa inyo, yung pregnant women, they have a growing fetus inside the uterus. And yung formation ng bone ng fetus at yung paglaki ng bone ng baby inside the uterus, it will need more calcium. It needs calcium. So saan makukuha ng calcium yung fetus or yung baby? From the mommy. So the mommy now will need more calcium. So, laging mas stimulate yung parathyroid gland ng mommy. Pwedeng mag-hypertrophy yung gland ng mommy. Okay? But if for example, no, parati namang mataas yung calcium mo, it can also decrease the activity and size of the parathyroid gland. Such as if for example, you're fond of eating or drinking foods that are rich in calcium. Okay, so mataas yung calcium mo, hindi mo kailangan masyado ng parathyroid hormones. Or if you're taking in vitamin D through supplement or perhaps vegetables, okay, so tataas yung vitamin D mo, parati kang tataasin yung absorption ng calcium, hindi mo kailangan ng parathyroid hormones. Or other causes of bone resorption. No, kung minsan kasi yung mga may cancer ng bones or ibang sakit, nagkakaroon sila ng increased bone resorption. So yung calcium and phosphate sa bone salts, labas sa plasma. So tataas yung calcium and phosphate ng patient. Okay? So, ano nga ba yung mga role ng calcium? Maliban pa sa muscle contraction na binanggit na natin kanina, pati sa blood clotting. We have mentioned that it is also important for yung sa membranes ng nerves, di ba? Sabi natin nerves and muscles. So ang ibig sabihin nun, it also affects nerve conduction. Okay? Kaya nga daw kung halimbawa mataas yung iyong calcium, you will have depression ng nerve conduction or transmission ng nerve impulses. Okay? If decrease yung levels, no, increase yung transmission ng nerve impulses, nagiging hyper-excitable yung nerves. Okay? Paano daw nangyayari yun? So going back, sabi natin kanina, di ba, it has a role in the stabilization of the membranes. So kung paano yun? Kung halimbawa ito yung cell membrane natin, no? If this is the cell membrane, no? If this is the loob ng cell, intracellular, this is yung extracellular. Okay? Sorry, ano ba yan? Sorry, palpak kasi yung tablet ko ngayon ay gumana. Outside the cell, di ba sabi niyo anong marami? Marami kang sodium. So, di ba marami kang sodium? So, ano nga dapat mangyari for nerve impulse to transport or for nerve conduction to occur? Ano yung isang dapat yung ma-produce? Anybody?
Action potential or
Ano yun?
action potential po ba?
Okay, correct. No? Para magkaroon ng action potential. Meron bang calcium sa action potential? Parang wala namang calcium sa action potential. No? Sabi natin, para mag-depolarize yung cell, sodium. Sa repolarization, potassium. Pero walang calcium. No? So, anong role ng calcium with regards to this one, no? Yung calcium natin, nasa labas din yan na ganyan, di ba? Nandyan siya. Okay? So in the presence of calcium, sabi, it somehow regulates the movement of sodium towards the intracellular area kapag may calcium dyan. So kahit pa paano, nare-regulate niya. Okay? Kaya daw, kapag halimbawa, mababa yung calcium hypocalcemic ka, what will happen? Yung sodium mo ngayon, they can easily enter the cell. Okay? They can easily enter the cell. Okay? Ganyan. Pasok na lang sila ng pasok. Kaya kung minsan, di ba, remember, kaya pagka isang stimulate mo lang sa nerve, dahil nga walang nagre-regulate, wala yung calcium, tuloy-tuloy ang pasok ng sodium. Kaya sila nagiging hyperexcitable. No? Paano naman daw kung hypercalcemic ka? No? Sorry. Madaming kang calcium na nandyan sa labas. No? Maraming kang calcium ganyan. So kahit daw kung minsan i-stimulate mo na yung cell kasi marami ka ng calcium, what will happen now? No? Yung sodium will have a difficult time going inside the cell. So, nabablock sila ng calcium. That's why, hindi ka makreate ng action potential. Nade-depress yung transmission ng nerve impulses. Okay? So, yan yung effect niya sa production ng action potential. Somehow, it regulates the movement of sodium towards the cell. Okay? Yan. Kaya pagka mababa na yung calcium mo, less than 8 mg per deciliter or less than 3.5 sa ionized calcium, you are now hypocalcemic. Okay, you are now hypocalcemic. So your nervous system becomes more excitable, and kung below 50% na, it may lead to tetanic muscle contraction and also seizures. Kasi nga sa brain natin, di ba, meron din nervous activity dyan. So kung hyperexcitable yung nerves mo, hindi na tama yung transmission ng nerve signals, it can now lead to seizures. Okay? Pero sabi nga natin, ang question is, sabi natin that we need calcium for muscle contraction. But dito, hypocalcemia, pero tetanic muscle contraction. No? Kasi remember, the calcium needed for muscle contraction are already intracellularly located. Diba? Nasa loob na sila ng muscle. But the problem in this, yung sa tetanic muscle contraction, is actually yung hyperexcitability ng nerves. Okay, remember, di ba, para yung muscle mag-contract, meron tayong motor unit. Di ba, pag tinawag mo motor unit, you have a nerve, you have a muscle fiber. Okay? Ang problem natin nandun sa nerves kasi nga hyperexcitable yung nerve. Kapag nag-send ka ng signal doon sa nerve, so yung pag stimulate mo yung nerve dahil hyperexcitable siya, send siya ng signal dun sa muscle. So yung muscle mo ngayon, contract until maging tetanic na yung contraction. Okay? Parang ito yung kung may mga kaibigan kayong madaling kilitiin. Diba? Ganun yung hypocalcemia. Diba? Yung isang talabit mo lang ganyan, tawa na ng tawa yung kaibigan mo. Ganun din yung nerve ng mga hypocalcemia. Isang stimulate mo lang, dire-diretso siyang magsisend ng impulse dun sa muscle, yung muscle mo contract. Okay? Kaya nga daw kung halimbawa less than 6 mg per deciliter na yung calcium, you will start to have tetany. At kung less than 4 mg per deciliter, it can become lethal. Okay? So ito yung one of the earliest sign ng tetany, yung carpopedal spasm, makikita nyo, flexion contraction ng wrist and fingers. You can also do some clinical tests to check for hypocalcemia. Ito yung isa, Vostek phenomenon or Vostek sign. No, ang gagawin mo dyan, you try to tap around 1 inch or 2 centimeters in front of the ears. Diba kasi nandun yung exit ng nerve. So kapag tinap mo yon, lahat ng muscle supplied by the nerve will contract. Makikita mo kaya pag tinap mo ganyan, yung mga hypocalcemia, magko-contract na ganyan. Yung muscles, sa eyelids, gano'n. No? So that is Vostek phenomenon. Ang isa pang clinical test that you can do, yung tinatawag nating trosusine. This time you put a BP cuff and inflate it. So yung pressure coming from the BP cuff will stimulate the nerve, which will lead to flexion and contraction din ng wrist and fingers. That is your Trousseau sign. Okay? So that's for hypocalcemia. For hypercalcemia, sabi natin naman, the transmission of nerve signals are depressed. So pwede kang magkaroon ng CNS depression, decreased QT interval, even the movement of the bowels will be affected. So babagal yung movement ng bowel, you will have decreased appetite as well as you will become constipated. So signs of hypercalcemia will begin to appear if the calcium is more than 12. If more than 15, magiging marked yung effect or mas grabe yung effect na or mas pronounced na yung symptoms. And kung more than 17, precipitation of calcium now may occur in other tissues of the body. Okay? So let us look at some syndromes associated with hypocalcemia. So yung unang-una is true hypoparathyroidism. So sa true hypoparathyroidism, this is caused by congenital absence of your parathyroid gland, no? Or since pagka-baby talagang hypoplastic yung parathyroid gland mo, no? So it is not functioning. Or sabi nga natin, kung if all of your parathyroid gland will be removed after thyroid surgery, yan, or accidental removal, you will now become true hypoparathyroid. So ibig sabihin, wala or decrease yung parathyroid hormones mo. This will decrease bone deposition and bone resorption. This will decrease the absorption of calcium in the kidneys as well as in the intestine, no? Kasi wala kang activation ng vitamin D. So what will happen? You will have decreased calcium and phosphate. Okay? Pag pseudo-hypoparathyroid naman, normal yung parathyroid hormone mo, but there's resistance to the hormones. Or kung normal nga yung amount ng parathyroid hormone mo, pero inactive naman sila or biologically inert, or you have inhibitors against your parathyroid hormones, or the receptor for your parathyroid hormone is abnormal, or you have autoantibodies that destroys your parathyroid hormone receptor. Kapag ganon, normal nga yung hormone mo but your kidneys are unresponsive. So decrease yung absorption, reabsorption ng calcium, and then increase yung phosphate reabsorption. Or ibig sabihin, decrease naman yung excretion ng phosphate. So what will happen now is that you have decreased serum calcium and increased serum phosphate. So yan yung pseudo-hypoparathyroidism. In your pseudo-hypoparathyroidism naman, both the hormone as well as your calcium and phosphate are normal. No? Ito kasing pseudo-hypoparathyroidism, this is a genetic defect wherein kamukha nila yung mga merong congenital true hypoparathyroidism. Okay? Sabi natin, pag congenital yung true hypoparathyroidism mo, so magmula pagkapanganak mo, wala kang parathyroid gland or hypoplastic, no, they're not functioning. So anong mangyayari? Remember, sabi natin kanina, importante yung bone deposition. So kung wala kang parathyroid hormone, walang tutulong sa bone deposition. Tapos decrease din yung calcium mo parate. Okay? So wala kang calcium for bone deposition. So ano mangyayari? Sabi natin kanina, yung pagka-baby tayo, bilog na bilog yung mukha mo. Di ba? So kailangan natin yung calcium for bone deposition to occur. Kaya para magkaroon ka ng high cheekbone, para maging prominent yung jawline mo, kasi kailangan mo yan ma-modify yung bone structure mo. So kung wala yun, no, kung congenital true hypoparathyroid ka, hindi mako-correct, kahit tumanda ka, bilog, hindi mababago yung facial features mo. And then, short stature ka rin kasi wala kang calcium used for bone deposition. Okay? Short din yung metacarpals mo. Ganun yung itsura ng mga congenital true hypoparathyroidism. Lalong-lalo na kung hindi na-treat. Okay? Itong pseudo-hypoparathyroidism, this is a genetic defect. Kamukha nila yung mga pasyente na yun. Okay? Ano naman kung meron kang primary hyperparathyroidism? So this can be caused by adenoma or carcinoma of the parathyroid gland. So you now have hypersecretion of your parathyroid hormones. When this happens, kung marami kang parathyroid hormones, what will happen? You have extreme osteoclastic activity. Okay? Kung meron kang extreme osteoclastic activity, pwede daw yung bones mo magkaroon ng osteitis fibrosa cystica. Anong ibig sabihin nun? So kung ito yung bone natin, di ba naalala niyo yung illustration kanina? Di ba meron kang mga canals. Dun sa canal mo, merong mga osteoblasts, di ba? Tabi-tabi sila, tabi-tabi sila. Tapos may mga osteoclast. Di ba? So kung extreme yung osteoclastic activity, anong ibig sabihin? Continuously, may bone resorption. So yung mga kanal na merong osteoclast, saka bone osteoblast sa bawat tabi nila, di ba pati dun sa sides meron eh. Tuloy-tuloy yan, magkakaroon ka ng bone resorption. So later on, yung bone mo, puno sila ng cystic spaces. Kaya tinatawag na osteitis fibrosa cystica. And because of that, madali rin silang ma-fracture or it will become brittle. Okay? Yan, no? Yan yung nangyari kapag meron kang hypersecretion of parathyroid hormones and extreme osteoclastic activity. And take note, dun sa kaninang diniscuss natin, for osteoclast to become mature, you need your osteoblast. That's why if you have hypersecretion of parathyroid hormones, there is also increased activity of osteoblast. And at the same time, increase in your alkaline phosphatase activity. Okay? And that primary hyperparathyroidism can also lead to parathyroid poisoning. No, because of the extreme elevation of parathyroid hormones, hindi lang yung osteoclastic activity ang increase. Increase din yung absorption mo ng calcium. So ang tataas ng husto yung calcium mo sa plasma. And at the same time, no, although sabi natin, pag parathyroid hormones, increase dapat yung excretion ng phosphate, di ba? Sa kidneys. However, because of increased osteoclastic activity, no? Dito sinabi natin. Ano ba yung malalize kapag increased osteoclastic activity? Yung bone salt, yung hydroxyapatite. And what is hydroxyapatite made up of? Calcium, phosphate, and hydroxide. So both calcium and phosphate will be released to the plasma. So dahil mataas na masyado yung calcium and phosphate in the plasma, it can now crystallize, no? And be deposited sa other parts of the body such as alveoli, kidney tubules, stomach, and arteries. So nagkakaroon ng calcification. Okay? Kasi nga mataas na masyado yung calcium and phosphate mo sa labas ng bones. Okay? Yan. Ano naman daw yung secondary hyperparathyroidism? So this is due to chronic decrease in serum calcium. O kagaya ng binanggit natin kanina. No? Kasi kung malaging mababa yung calcium mo, you need more parathyroid hormones. So your parathyroid gland can increase in size or it can hypertrophy. So you can see the secondary hyperparathyroidism sa patients with chronic renal diseases. Kasi yung mga patients with chronic renal diseases, affected na rin yung absorption ng calcium. So they will become hypocalcemic. Okay? In rickets, in osteomalacia, no? Kanina binanggit na natin yung pregnancy. No, ganun din kapag ka naman nanganak na si mommy, naglalactate na. Kasi in order to produce milk, the mommy needs calcium. So again, pwede pa rin silang, kahit na nanganak na, pwede pa rin may secondary hyperparathyroidism due to lactation. Okay? So ano ba yung rickets? Kanina pa natin nakikita si rickets. So rickets is deficiency in calcium and phosphate due to lack of vitamin D. Due to lack of vitamin D. So madalas itong nakikita dun sa mga, especially in children who lives in very cold countries as well as yung mahaba yung gabi or yung winter time nila. Diba? Kasi kapag parating malamig, anong tendency for you, ikaw as a parent or yung mga adults, ang tendency niya, lalo na sa kids, diba, pag gamitin ng makakapal yung mga bata, tapos naka-jacket. And then most of the time, they will stay indoors. Diba? And if you are indoor, anong nangyayari? Wala kang exposure to sunlight. So walang conversion ng sterol compound sa skin mo to become vitamin D3. So magkakaroon sila ng vitamin D deficiency. And take note that these children, hindi naman sila mahilig sa gulay. Diba? Which is a source of your vitamin D2. Diba? Kaya itong mga pasyente na to, they can have rickets or vitamin D deficiency as well as deficiency of calcium and phosphates. Kaya ang isang manifestation nitong mga patients with rickets is what? Thin din yung bone nila kasi nga wala masyadong calcium, walang calcium to be used for bone deposition. So manipis yung buto nila. Kaya isang makikita yung sign ng rickets, di ba yung ribs, may bone deposition din dapat yan. Dahil wala sila masyadong bone deposition, manipis yung bone nila sa ribs. So parang nagpo-protrude yung mga, di ba yung rib, yung head niya may cartilages. So parang nakaprotrude yung mga cartilage dun sa ribs nila. Okay? And then aside from that, dahil weak nga yung bones, prone sila to fracture. Prone sa fracture itong mga batang ito. Okay? So lalo na kung below 7 na yung calcium, they can also have tetany or tetanic muscle contractions. At kung hindi pa makorek, no, sabi nga natin, kung below 4 na yan, pwede na maging lethal kasi even the respiratory muscles will undergo tetanic spasm. Okay? And actually, this is not only true for children, no? Pwede rin, especially nowadays, di ba, yung usong-uso yung mga home care facilities, yung mga matatanda, di ba, yung mga those who are old age, nilalagay sa home care facilities. Uso din yun, di ba, sa ibang bansa. Sa atin, di masyado eh. Sa ibang bansa, uso yun. So, yung mga older individuals na nasa home care, lalo na kung malalamig yung panahon, sometimes they tend to stay indoors as well. So, wala ring exposure to sunlight. Okay, later on, they can also develop rickets. Pero nga ngayon, uso na yung vitamin D supplementation because somehow, nalilesen na din yung chances for them to develop rickets. Okay? Ano naman yung osteomalacia? In osteomalacia, you have problems in fat absorption. So you have fat malabsorption. So if you have fat malabsorption, you will now have failure to activate your vitamin D. And take note also your vitamin D, this is a fat-soluble vitamin. So if you have fat malabsorption, absorb yung vitamin D mo as well as other fat-soluble vitamins will be affected. Okay? So kung wala kang vitamin D, decrease din yung absorption mo ng calcium. So what will happen? Diba? Affected din again yung bone deposition. So this is osteomalacia. This is due to fat malabsorption. Maliwanag? So let us also somehow discuss yung congenital hypophosphatemia. Kasi minention kay Guyton eh. So ano naman si congenital hypophosphatemia? In your congenital hypophosphatemia, you have failure to reabsorb phosphates by the kidneys. No? So siguro nawawala yung sinabi natin kaninang overflow mechanism. So excrete ka lang na excrete ng phosphate. So ang mangyayari, mababa din yung phosphate mo sa katawan. Okay? So kung mababa yung phosphate mo sa katawan, decrease yung phosphate mo. 'Di ba? Sabi natin hydroxyapatite, you need phosphate, no? Yung sa bone salts, kailangan mo rin phosphate. Di naman panay calcium lang eh. So these patients with congenital hypophosphatemia, they will manifest as rickets. Manipis yung bone because of decreased bone deposition, brittle din yung bones nila. However, so ang unang akala sa kanila, rickets. So they will be given vitamin D. However, kahit bigyan sila ng vitamin D, no, walang effect. No? Wala pa ring effect. Kaya sila yung tinatawag na vitamin D resistant rickets. Kasi to begin with, hindi naman vitamin D yung problem nila. But ang problem talaga is with the reabsorption of phosphates in the kidneys. Okay? Ito kasi dapat kadugtong dun sa estrogen kanina. No? May isa pang effect, no? Yung estradiol, calciotrophic din siya. It promotes osteoblast survival. No? And then it also increases intestinal calcium absorption daw. And then it promotes apoptosis ng osteoclast. Ano ibig sabihin ng apoptosis? Cell death ng osteoclast. No? Kaya kung wala ka masyadong osteoclast, di ba kanina si estrogen promotes yung release ng osteoprotegerine, which is a competitive inhibitor ng rank L. So nawawala ng maturation ng osteoclast. No? Tapos aside from that, yung estradiol daw promotes yung cell death ng osteoclast. So, ano nangyayari? Decrease yung osteoclastic activity. That's why premenopausal, diba, low yung risk ng osteoporosis in women. Pero pag postmenopausal na, increase na yung risk for osteoporosis. Okay? O yan din yung sa glucocorticoids. Okay, I think so that's it. No? Unless you have questions. So